Hello and welcome to Dopamine. Today we'll be looking into the topic neonatal resuscitation from pediatrics. Okay, so without wasting our time, let's directly dive into it. So, what is neonatal resuscitation? So, neonatal resuscitation refers to an immediate and sequential interventions to establish what? So, breathing and circulation in a newborn who fails to adapt to extrauterine life. Okay, so the basic explanation I'll explain. Whenever the baby is born, okay, so baby is born, baby is born. So what happens when baby does not cry? Okay, baby does not cry, and there are no vitals, heart rate, blood pressure, SpO2 saturations, all these things are decreased. So that time we need to start an protocol to like revive the baby. Okay, so this is known as neonatal resuscitation, and which we need to follow in a sequential interventions. Okay, like we need to check the parameter, then we need to do this thing, that thing, and all this. Okay, so what are the causes? What things can cause such a thing? Okay, so first and foremost is perinatal asphyxia, like decreased SpO2 saturation. And then we have the prematurity like preterm babies with premature lungs. Directly we can say that underdeveloped lung surfactant and alveoli will lead to a decreased amount of SpO2 saturation. Then we have the meconium aspiration. Then we have the umbilical cord accidents like prolapse, knot, abruption. And then we have congenital anomalies like diaphragmatic hernia. And then we have the maternal medicines, example the use of opioids or the use of MgSO4. And there are severe infections or chorioamnionitis. So these are the possible causes which can lead to the alterations in vitals of the baby, and which can lead to the emergency protocol of neonatal resuscitation. Okay, so pathophysiology, let's look into it. So at birth, whenever the baby is born, there is a normal transition. Okay, so there is a normal transition like the fluid clearance, lung expansion, onset of breathing, and increased pulmonary blood flow, like fluid clearance, like the removal of meconium. Okay, removal of meconium, then lung expansion, like the baby starts to breathe, starts to breathe. And then we have the increased pulmonary blood flow, for the saturation of hemoglobin, in order to provide oxygen to the complete body. Okay, and asphyxia, so this is the normal transition. Okay, so what could go wrong? So asphyxia, the most common cause is asphyxia. Okay, so which is a lack of oxygen. So lack of oxygen can lead to three different things. Okay, two different things, and prolonged will lead to one more thing. So first and foremost is the bradycardia. Okay, so decreased heart rate. When there is a decreased heart rate, so the cardiac output will be less, hence there will be decrease in blood pressure. So whenever there is a decrease in blood pressure, so let's write it down here, decreased heart rate will lead to decrease in blood pressure. So when there is a decreased blood pressure, so poor perforation, let's not say perforation, poor delivery of the oxygen to the organs. the organs. Hence, there will be a deficient O2 at the organs, and which will lead to the multiple organ failure. Okay, so this is the clear explanation. And then we have the acidosis, metabolic imbalance. So acidosis will lead to the reduced cardiac output. Okay, and if this both of the things are untreated, okay, untreated, then it will lead to hypoxic ischemic encephalopathy, and this will ultimately lead to death of the baby. Okay, so you need to only remember about the asphyxia will lead to bradycardia will lead to hypotension will lead to the poor delivery of the oxygen to the organs, and deficient oxygen at the organs, and then multiple organ failure. And acidosis will lead to reduced cardiac output, and if these both things are not treated, then we'll have hypoxic ischemic encephalopathy. Okay, so what are the signs and symptoms? Signs and symptoms, what we can see is there is an absent or irregular breathing. First and foremost, always, as we say, we always need to see ABC. So first and foremost, we'll be looking at airways. Okay, then we'll be looking at breathing, and then we'll be looking at circulation. So why airways? First and foremost, so airways just be when the airway is clear, our respiratory system is clear, then the oxygen will be available. So oxygen will be available, hence it will perfuse all the organs, like or normal transition of the oxygen from the outside into the our hemoglobin will take place, and all these things will be going. Okay, so airways are the important, and then we'll see the breathing. So breathing, we can there will be a normal, and then we have different things like shallow breathing, rapid breathing, okay, tachypnea, and all those things. Okay, so first sign and symptom will be looking absent or irregular breathing, and then we'll have the central cyanosis. Central cyanosis, why? So whenever there is a decreased O2 saturation, so it won't be provided at the terminal end. So there's a reason it will lead to increased CO2 in the circulation, and the color is dark. So hence it will the color is dark of the CO2 present in the blood. So hence it will lead to the bluish discoloration. Bluish discoloration. So we'll have the central cyanosis, and the baby won't be of a good tone. It will have a floppy tone, and the heart rate will be less than 100 beats per minute. There will be no cry, and there will be no response to the stimuli, and will have a low Apgar score, which is 0 to 3 in 1 minute. Okay, so these are the signs and symptoms. Mostly we need to always check the airways, breathing, and circulation. These three things will determine the further outcome, like the further what all things we gonna do. So if the patient is untreated, so what are the complications that can be seen? So first and foremost complication we'll be seeing is hypoxic ischemic encephalopathy. Then we'll have the intraventricular hemorrhage. Then we'll have the persistent pulmonary hypertension of the newborn. Then we'll have the multiple organ dysfunction. Then we'll have the neurological sequel like cerebral palsy, death if untreated or delayed. Okay, so these are the complications. Just for namesake, you need to remember, or you can directly correlate. With the pathophysiology, that what are the outcomes, like what the complications can be caused. Okay, so now before starting the algorithm about the neonatal resuscitation, let's understand what are the initial assessment, what other things we need to see, and all those things. Because if we understand this, then it's more clear for us to understand the algorithm, neonatal resuscitation algorithm. So initial assessment as a pediatrician, for whenever the baby is delivered or whenever this baby is going to be delivered, so we should have the four questions. Okay, so like for what? So in order to predict the outcome of the delivery, so the first question is the term gestation. Okay, so there will be preterm, there will be the full term, or the post term. Okay, so these are the three, and you need to know the weeks, at what weeks they are being delivered. And then we have the was the clear amniotic fluid present or not? So it's yes or no. And are there any risk factors present, maternal or the fetal? You can get this in the USGs, which are been done in the ANC. Okay, so like Doppler study, and all those things, like any anomalies present or not, or are there any other risk factor in the mother side. So maternal side, if we see maternal side, then we can consider the gestational diabetes, and then we have the hypertension, pre-eclampsia. Okay, and these are the main ones, and there are others as well. So, and then we need to ask the fourth question, which is umbilical cord management plan. What are we going to do when the baby is delivered with the when the baby is delivered? Okay, and what are we supposed to do with the umbilical cord? So first is delayed cord clamping. Okay, so delayed cord clamping for 30 or 60 seconds after birth. But the catch here is only if baby cried after birth. Whenever the baby cried after birth, that time only will be doing the delayed cord clamping. Okay, so and other this about umbilical cord is cord blood for the newborn screening taken or not. So this will give us the like predictable outcome. Okay, predictable outcome, like what all things we need to do. And then so now the baby is born. So what are the priority management that we are supposed to do? Okay, what are the priority management that we are supposed to do? So the priority management is, first and foremost, we need to check the respiration. Okay, so respiration, so how you will do? So cry after birth. If baby cries after birth, that means it is a normal respiration. Okay, and then we have the temperature. You need to note it down and keep baby under warmer, or like skin contact with mother, which is known as kangaroo care. Okay, and then we need to check for the circulations, like on the distal end, circulation is good or not, heart rate, and all those things. Okay, so these are the priority management of the newborn. We need to check respiration, temperature, and circulation. So proceeding on forward, like now, how do we check if there is a temperature decrease, what is if there is a breathing issues, or if there is an airway issues, so how we'll deal about it? Okay, so first is the temperature. We need to keep baby under the warmer, or skin to skin contact we can give. And then we have breathing. So okay, so breathing, if the baby is not breathing properly, so what we need to do? We need to give a gentile tactile stimulation. Okay, so we need to give gentile tactile stimulation. So how we'll give? So method is rubbing over the back with a cotton towel, or flicking the soles. So this will initiate like the breathing pattern, or it will stimulate the baby to have a normal breathing pattern. Okay, and airways. Okay, so in the airway, if there is an airway obstructions, or the baby is not breathing properly, like taking the oxygen properly, so we need to position the baby properly. So how will position? So it's a slight extension of the neck using a towel under shoulder, which is known as sniffing position. Okay, so you can see over here we have a sniffing position image over here. So first is like the it is horizontally aligned. You can see over the baby is horizontally aligned, the face. Okay, and then the second, we need to see the neck should be wide and open, it should be visible, this area should be visible for us. Okay, and then we have the external auditory meatus and suprasternal notch plane, so it should be horizontally aligned. So you can see over here that it is horizontally aligned, and we need to keep the towel. Okay, we keep towel under the shoulder, and then we have the headrest. So this is the sniffing position which is done to achieve the opening of the airway. Okay, so and then we have like if there is some kind of secretion, there is some kind of secretion, so that time we need to perform a suction. Okay, but when we'll do only if visible secretions are present. And now here the most important thing is, whenever we are doing a suction, we should always and always, even in adults and pedia, we need to remember that order should be from mouth to nose. Okay, so why? So from mouth, whenever the patient whenever there's fluid, okay, whenever there's fluid present in the mouth, okay, so there are chances that that fluid could enter into the lungs, and hence aspiration happens and there is a fluid present in the lungs, so which we cannot remove, and the patient condition worsens step by step. So always remember that we should perform suction from the mouth, and then we should go to the nose. Okay, and one more point I would like to add, which is like if any patient is having vomiting or if there is fluid present, so we should always lie that patient into left lateral position. Left lateral position. Okay, so I hope till here you have like clear understanding what is the sniffing position, what we should do about the temperature, what we should do about the breathing, and what we should do for the airways. Okay, so now let's see the assessment of the heart rate and the respiration. So first and foremost, so whenever there is a no cry after the birth, which signifies there is no breathing. So when there is a no breathing, we can say that there is a significant hypoxia because decreased O2 saturation levels. Okay, and due to hypoxia there will be a decrease in heart rate, which is mostly less than 100 beats per minute. So normally if there is a newborn, so the heart rate will be more than 100 beats per minute. So now how will assess the baby? Okay, so assessment of the baby, if heart rate is more than 100 beats per minute plus there is a poor or labored breathing, so what we need to do that time? So we need to give O2 supplements. How will give? Will give by O2 hood, which is box over head, or the nasal prongs. And here we need to remember if the baby is preterm. Okay, if the baby is preterm, then we need to give continuous positive airway pressure, CPAP. Okay, which is less than 32 weeks. So this is for preterm, and if there is a term baby, only O2 supplement is necessary. And if so, here we have this scenario is the critical scenario. Here scenario. Okay, so if the heart rate is less than 100 beats per minute, or the baby is not breathing, or there is an apnea, so that time we need to intubate the patient and start we need to give the positive pressure ventilation. Okay, so how will give? So in what do you say, whenever we are putting the baby or the any adult on the ventilator, we have invasive and non-invasive mode. So first and foremost we'll go with the non-invasive mode. Okay, so non-invasive mode will give bag and mask ventilation used initially with PPV. Okay, so positive pressure ventilation, and then when there is no recovery in the heart rate or the saturation, so we'll go for the invasive method, which is endotracheal tube, and will maintain the saturation. I hope this scenario is understood well enough. And if you have any doubt about it, you can like put it in the comment section and I'll get back to you. Okay, so now let's look into the assessment of heart rate and respiration non-invasive mode, because this is the critical case scenario. And we need to be thorough about it, that what are we going to do with bag and mask ventilation, what are we supposed to do when the baby is intubated. Okay, so the volume which we need to give is 240 to 750 milliliter, and at what rate? So at 40 to 60 per minute. Okay, so now how will monitor? So response monitor will be if the heart rate of the baby is more than 100 per minute. Now the crucial things, so what is the pressure that we gonna apply? So first, the first pressure should be 30 to 40 centimeters of H2O. So why? So it will the initial is high because it will open the stiff airways. Okay, it will open the stiff airways, like this is okay. So this is constricted. Okay, let's see, this is the trachea which is constricted, bronchus is constricted. Okay, so now let's consider even more. So now we apply the let's say 40 centimeter of H2. Okay, so what will happen? It will exert the pressure on the walls. It will exert the pressure on the walls, and that will lead to an opening of the vessel. Okay, opening of the vessel, and hence the oxygen can flow through it. Okay, so after the first pressure, the continuous things will be subsequent will apply is 12 to 20 centimeter of H2. So why? First we gave higher, then we gave lower. So what's the reason? So the lower is for to prevent hyperinflation or rupture of the alveoli, because the pressure is way too much high and the alveoli cannot bear it. So we'll put it around the settings where the alveoli will not get ruptured, or there is to prevent the hyperinflation. Okay, so now FiO2 based on the gestational age. Okay, so these are the settings. FiO2 settings is present in our ventilator. So if the baby is more than or equal to 35 weeks, so at room temperature, at room air, we need to give 20% of O2. Remember this one. And if the baby is less than 35 weeks, so initially we'll start it with 21 to 30% O2, and then we'll tighter to targeted SpO2, which is measured at the baby's right hand. So targeted SpO2 titration will look into the coming slide, but just remember that we have to titrate. Okay, so now why we need to titrate the oxygen to the targeted SpO2? So now see, and whenever we give an excessive O2 to the preterm baby, so there will be hyperoxia damage. Okay, so what is this? So it will lead to the retinopathy of the prematurity, and it will ultimately lead to the blindness. So always titrate the SpO2 to prevent the blindness. Okay, even in adults, but mostly we'll consider it in the neonates. Okay, so now FiO2 based on the gestational age, what are we supposed to do with it? So minutes after birth, if the baby 1 minute, say 1 minute has been happened, then we need to target it to 60 to 65, and in the next second minute we need to target it to 65 to 7. In third minute we need to target it to 70 to 75. 4 minutes 75 to 80, and 5 minutes 80 to 85, and in 10 minutes we need to get till 95. So this will prevent retinopathy of the prematurity and the blindness. Prevent. Okay, so we need to remember, you can take a screenshot of this. And okay, now let's look into some of the steps, like whenever we are not getting the adequate result, whenever we are not getting a proper result of the what do you say, proper result, that increase in heart rate, increase in SpO2 saturation. So these are the things we need to look into it. Okay, so ventilation correction. Okay, so ventilation correction step if the response is inadequate. So first and foremost is the mask repositioning. So incorrect position is the most common cause of inadequate response. So what do we see here? Let's keep the correct one aside and see here. The first one is the size of the mask. Size is more. Okay, it's not on like the adequate size for the baby. So what will happen? The oxygen will flow out and there will be inadequate oxygen available for the baby. And even here there is a small size, so same thing will happen. And if there is a normal size and you're not, the placement is not clear, placement is wrong, that time will not have. So this is the correct position. Okay, so this is the correct. So now we can see that size is adequate. Okay, and there is proper positioning over the nose and the mouth. Okay, so this is the correct position, so you need to remember the correct position. And then we need to readjust the head position, like the sniffing position you have seen already. Okay, and then suction, remove all the secretions if there are any available, open the mouth, and pressure increase over the bag in bag and mask ventilation. And alternate airway is ET tube, endotracheal tube, and endotracheal tube is absolutely contraindicated in diaphragmatic hernia. Okay, so these are the things that these are the 6 points which you need to remember. And I guess there is a mnemonic for it, which is MR SOPA. MR. Okay, so M stands for mask repositioning, and R stands for readjust head position, S for suction, O for open mouth, P for pressure increase over bag, and A is alternate airway. Okay, so now let's go into the invasive. Still we are looking at the critical case scenario. The first one we looked is non-invasive. Let's go to the invasive. So we need to have like the endotracheal intubation. Okay, so endotracheal intubation means like laryngoscope and all those things will be present. So how we'll do? So visualization of the airway via straight blade laryngoscope. Okay, we are going to use this straight blade laryngoscope. Okay, and so like size 0 for the preterm and size 1 for the term. You need to remember only this one, and the main is this straight plate. So now type of endotracheal tube. Okay, so it is an uncuffed. You can see over here there is like no cuff present over here, no cuff present. Okay, in adults we have cuff present, we need to inflate it with the air. Okay, so why? So to prevent the pressure to prevent pressure tracheal necrosis. Okay, it is due to the cuff pressure on the narrow subglottic area. So this is our trachea. Okay, so if the baby is having, because the body is not developed properly, so it will what, it will exert a pressure on the trachea. So what will happen, will the baby will have pressure tracheal necrosis. Okay, and then we have the inner diameter of the tube. So based on the weight of the baby we'll be doing it. So less than 1 kg, it's 0.5 mm. If the baby is 1 to 2 kg, 3 mm, and if the baby is more than 2 kg, 3.5 mm. So now the main thing is we need to like what do we say, we need to see the end tidal CO2 estimation for determining if the placement is correct done using capnography. Okay, so here we have a capnography. Here we have a capnography. So you need to look at this point. This is the normal scenario. This is the normal. Okay, so the graph on the ventilator should look like this. That means that you have placed a proper ET. Okay, and now the insertion depth. What will be the insertion depth? It is a nasotragal length plus 1 centimeter. So you need to calculate the length from the nose to the tragus, and you need to add 1 with it. You will get the insertion depth, how much you need to insert. Okay, and now let's look into the chest compression thing. So chest compression is done alongside the ventilation, okay, by the two person whenever the baby is intubated or non-invasive bag and mask ventilation. Okay, and the rate should be 3:1, which is 90 compressions and 30 ventilations in 1 minute. And the response monitoring will be using a cardiac monitor, which is heart rate more than 60 beats per minute. Okay, then if all these things fails, then we have the adrenaline. The preferred route is IV, which is through umbilical vein, and if inaccessible, we have the intraosseous route. So here you can see over the intraosseous route, we put it into the bone. Okay, it is inserted into the bone, and then the IV fluids are administered. Okay, and what are the dose? The dose of the adrenaline is 0.2 milliliter per kg, and the strength is 1 is to 10,000. Okay, so now I hope that you have understood all the steps, what all, where we gonna use, how much values we gonna put. So now let's look into the resuscitation algorithm, which is the most important. Okay, so let's see. So initial assessment. Okay, initial assessment will be asking the 4 pre-birth question. Okay, and if the baby does not have any cry, okay, if the baby does not have any cry, so initial steps will be to record the temperature, airway, and circulation. And even baby does not cry after that, so we need to assess the heart rate and the respiratory efforts. So here the first minute is a golden minute of neonatal resuscitation. So the baby is born and all these things you notice though. So you need to take the action like without thinking. You need to remember this resuscitation algorithm and directly jump into it without wasting a time, without getting a consult. You directly start on this. Okay. So now you have assess heart rate and respiratory efforts. So you have already seen the steps. So after, if the heart rate is less, even if after assessment of heart rate and respiratory efforts, if the heart rate is less than 100 beats per minute, then then we remember that the positive pressure ventilation, okay, with bag and mask ventilation or the endotracheal tube. And if after positive pressure ventilation the heart rate is even less than 60 beats per minute, then we need to start the chest compression with ventilation, and then we need to administer the adrenaline. You remember 0.2 ml per kg, and if there is no response, so we'll be considering a volume lung expander, which is NS, will be giving 10 milliliter per kg. Okay, so the duration will be doing for only for 20 minutes, and if there is a no response, then we need to declare death of the baby. Okay, and well, yes, volume expansions can only be used if the documented significant maternal antepartum blood loss in the baby. So this is the resuscitation algorithm which you need to remember, you need to directly put into an action whenever the baby is delivered and Apgar score is less. So you need to follow these steps. And I hope that you have understood this lecture, and I hope that you have gained some knowledge out of it. If you have any kind of doubt, please do let me know in the comment section. I'll be happy to help. And if you need the notes, I'll link it down in the description so you can download it, or else I'll leave my email over there so you can directly mail and get the notes. Okay, so thank you for watching. Make sure to like, share and subscribe, and even share it with your medical mates and whoever in need. And thanks a lot for watching. Have a good time. Let's meet in the next lecture.